Hi, this is Dr. Kathy Vierhusen going over the video for this week. This is week 5 in community wellness. We're going to study communicable diseases and epidemiology this week. You've already, I think, been diving into that. This is a very basic coverage of those concepts. If you were becoming a public health nurse, you would certainly have more information on this. If you were getting your master's degree in public health, which I would highly recommend, those of you that want to go into public health to pursue your master's degree, you would certainly get a lot more information, particularly on epidemiology and understanding all the different idiosyncrasies of that. It's a fascinating area of science. But today we're just going to skim the top. You've had a lot of exposure to it from COVID already, just in your public awareness of what's going on with that. And so we will go over our PowerPoint. Remember, you can go to your PowerPoint on Blackboard and you can utilize that for taking notes. It also has the notes on there, so you don't need to be frantically writing notes when I'm going over definitions and things like that. You don't need to do that. The notes are there for you, but I do want you to listen and get the concept of what we're talking about this week. So I'm going to share my screen with you, and I am going to then bring up the PowerPoint presentation. And we'll go ahead and go to a slide view on this. Okay. All right, so week 5, epidemiology and communicable diseases is what we're going to be talking about. And so I'll start this out by taking us away from COVID and talking about something else that happened as far as an outbreak. And so this was in the summer of 1976. 2 African towns were struck by a mysterious illness that killed most of their population. So these 2 villages in Africa actually had their populations completely wiped out by an illness that they weren't sure what it was. They originally suspected that it was the dreaded Marburg virus because of the symptoms. The Marburg virus was a hemorrhagic fever, and they thought that was indeed what they were dealing with again. But they were surprised by the number of people that died from it. When we talk about morbidity and mortality rates in public health, when we talk about mortality, we certainly are talking about how prevalent it is for someone to die once they contract a certain disease. And this one had almost 100% death when somebody contracted it. But when the healthcare workers looked under the microscope, they actually saw what you see on your screen right here is this gray-blue kind of worm-looking virus that's amongst the red blood cells there. And that certainly wasn't the Marburg virus. That's not what they were looking at. It was something new. It was very scary. They didn't know what they were dealing with. They saw it, they felt it had something they had never seen before, and it was a new pathogen. And this is exactly what we worry about when we talk about communicable diseases, something we haven't seen before, something that we haven't built up any immunity within our bodies for. And it was caused again, severe hemorrhagic fever, which means people bled, right? Hemorrhaging means to bleed. So they had fevers and then they bled, and they bled from their orifices. So they bled from their eyes, from their nose, from their mouth, from their ears. So that was very scary to witness as well. It was our first encounter with Ebola in 1976, and it was named by a nearby river. So if you ever wonder where things get named by, it's usually the person that discovered it or some geographic location that was attributed to it. On this next graph, though, here, we can see this is number of deaths. And you can see in 1976, those 2 villages accounted for 600 deaths. And 600 deaths, right, in the big picture is probably not that big. I mean, it certainly is for those individuals and for those individual families. But what I'm saying is 600 deaths in itself was not the scary part. What was scary was the almost 100% mortality rate with it. So once somebody contracted it, most likely they died from it. And so we had to really contain Ebola. And as soon as they started investigating it, you know how long it's been taken for COVID to be investigated. It's been almost a year now. As soon as they started investigating it, after the people had died, they didn't have any more deaths. You can see in 1977, they had 1 person. In 1979, they really didn't have very much. 88 had 1, 89 had very, very few, 94 a few more, and then, a few more in 95 popped up. And so now they're like, oh, well, we need to pay attention to this again. I covered last week in how we determine resources, right? So if something's no longer a threat, like nobody's dying from it, nobody's catching it, then they decide that they don't need to put the resources towards that because resources are what? Limited, right? They're limited. And so we decide where our resources go, money and the people. We're not going to go and try to figure out what Ebola was and how to cure it if they were having no more deaths. But now in 95, they saw a few, 96, a little bit less. We had a spike in 2000. 2001, 2002, and then it dwindled down. 2007, we saw another spike. 2014, we saw another spike. And 2014, by the end of the year, this is actually one that was taken in April. By the end of the year, it really had surpassed the 600 deaths. And so then they realized they needed to do something about it. And if you remember, and the CDC became involved with it, and you will either have seen or will see that a CDC short video on how they responded to that. But let's take a look at really what our response to that one was. Because it had such a high mortality rate, we really took all precautions that we could. And we didn't have 500,000 people have this. So the people that did have it were treated with medical personnel that had full PPE, because that's where that resource went, and we didn't need it anyplace else that was in so dire need. So you may remember people coming home, American citizens coming home from working overseas. Perhaps they worked in missionary work, perhaps they work in healthcare, and they contracted this, and they came home, and when they got off the airplane, they were met with what looked like an adult-sized incubator, right? It was like covering them. This whole big plastic thing was covering them, and air was going in, and negative airflow so that Ebola wouldn't get out into the air. But I put myself in the place of this young child that's being helped by a healthcare worker. How scary is that? This child most likely is going to die from Ebola. That's the reason she's being cared for by a healthcare worker that actually has full PPE. And how scary that must be. This must just look like a monster to that little one. So they decided that they were going to investigate that. And really, you're going to read a little bit about it or hear a little bit about it on the videos this week about what actually happened from that. Very similar in the transfer from the animal world over to the human world on our what we suspected. So that's the reason that we kind of take these things really, really seriously. But when we're looking at what we're most concerned about, we need some numbers to compare, and that's where we look at mortality and morbidity rate. We're going to talk about that in just a little bit, but it really is important for us to be able to contrast and compare how deadly is this disease versus this other disease. How are we worried about this disease versus another disease? For instance, everybody gets a coronavirus at some point during their life, probably several times, because the common cold is caused by a coronavirus. But it's the corona, right? This SARS-2, this COVID-19, this novel coronavirus that really is the one that's causing us problems right now. And so we really do need to know which ones we concentrate on, where the dollars are spent, where the resources go. What do we actually look at? There are a whole group of diseases in the world that get very, very little attention because so few people have them, or so few people die from them. And so Ebola caught the eye because it was scary. If this had become a pandemic, we would be looking at much higher amounts than we saw in the 1918 flu epidemic. But it did get contained, and it has been contained very well by the people that are working, the professionals that are working on that. So I just wanted to bring up another outbreak. You will read a little bit about that this week. So this is just a slide to tell you, overall health that we constantly as nurses are supporting means, complete physical, mental, and social well-being. And then we are supporting that by protecting, promoting, and optimizing health and abilities. And we certainly do that in community health. We are looking, how do we protect our public from things that could negatively impact their health, and how do we keep them healthy? How do we screen for things that are silent and they don't know they have them, like diabetes and hypertension? And then what kind of social enterprise we put in support of that. Here are some definitions that I just threw them up here so that you would be exposed to them. I don't expect you to know all of them by memory, but epidemiology, it's really the study of the occurrence and distribution of health-related states or events in specific populations. And it really looks at the social determinants of what's happening with those and how we can control those health problems. Descriptive epidemiology seeks to describe the occurrence of diseases as far as person, place, and time. And we've seen that many, many times, but most recently, again, with the coronavirus, where we say, where did it come from? Who has it? Who is patient zero? What was the time frame that it was actually released? When did it actually come over to America? Who was the first person in America that actually had it? We don't know the answers to those right now. We've talked about determinants of health. Analytic focuses on investigative causes and associations with what the disease is. And then we look at distribution. Of course, we look at whether or not it's becoming epidemic. And really what we mean by that is really what is the rate of occurrence, how quickly is it spreading, how well can we control it. So we have some historical events that we look at when we're talking about epidemiology. Hippocrates, of course, understood health and disease in a community. He was the first one that really publicized that or published about that. And then we really looked at, in the 18th and 19th century, we got information in epidemiology, which really looked at control groups versus comparison groups. You learned a lot about that, right, in your research class. But that was really the first time that happened. And I think it's amazing to me that it's only been in existence a couple of hundred years that we scientifically looked at these things. And then John Snow, if you ever read about him, he was the first physician that actually linked cholera to a water source for all the cholera outbreaks that we would have. People would die in the thousands of cholera within an area. And he was the first one that really identified that. So he's considered the father of epidemiology. And then what we have seen within the 20th century, the 21st century, is we have seen our life expectancy, which is one of the biggest metrics for us looking at a community health, is what is your life expectancy. We've seen that dramatically increase. You hear people kind of kid about that, but 100 years ago, 150 years ago, you're out working in the field, we didn't know anything about disease, people didn't have any preventative health care, and didn't understand anything about nutrition, and didn't have the certain medications we have, and people lived to 30, 40, 50 years old. And now we certainly have our life expectancies in the 70s and the 80s. And so we have seen a decrease in communicable diseases or infectious diseases worldwide, obviously more in our developed nations. And thus people are having an increase in chronic diseases because we've eliminated the deaths from the infectious diseases earlier. It used to be in my grandmother's time, so I'll say, around the turn of the 1800s to the 1900s, turn of the 20th century, where people were actually, when they would have children, they would expect all their children would not make it into adulthood, that they would die of, like I said, cholera, TB, measles, mumps, rubella, things that we have immunizations for nowadays. And they would expect that they would not have their children all live to adulthood. And of course, that's inconceivable to us. We have a child in this day and age, and we call it tragic if they die before their parents do. So we have come a long way. So basic concepts, morbidity is really the ratio of the number of cases of a disease or condition to the number of the population. That's basically it. And we talk about comorbidities. That's where that word comes from. It really talks about the disease process. So when we talk about comorbidities, we talk about other diseases the patient has. But when we talk about morbidity rates, we talk about a particular ailment, illness, and we say how prevalent really is it in the community. And so you might have a certain community that has a high incident of obesity and another community that doesn't. And then we want to contrast and compare those communities and say, what makes this one more prone to having obese individuals and this other one doesn't? And I'll tell you, most of the time it has to do with the availability of fresh foods, and the affordability of fresh foods. And then the availability of safe exercise venues. And then mortality, of course, has to do with the number of deaths within a certain area. We're going to look at a couple of models here in this PowerPoint and look at levels of prevention. Okay, so I just went over this. Really, we talk about the ratio of the number of deaths to the number of people, and really under morbidity, we're talking about incident, prevalence, and survival rate. Survival rate has to do with once someone is diagnosed with it, how long until they succumb from that disease. And so if you take cancer, that's an easy one to think about in this context. You take cancer, and if you had pancreatic cancer in the past, the fact that when they diagnosed you until you were, till you died from that pancreatic cancer would usually be about 6 months. I mean, it was many times it was less. I've known people that were diagnosed and they died within 6 weeks because it was something that was diagnosed so late. And now you can have pancreatic cancer. Alex Trebek, and I will hold him up as an example. He's had it for 2 years now, so that really that survival rate has really increased. And so these are just some of the things that we look at. I have put calculations in this PowerPoint presentation just as illustrations. I am not going to quiz you on actually doing the math. I think the math is fairly simple. If you look at this, let's look at the rate of teenage pregnancy on this particular one. So we know we want to take the rate, and then we're going to divide the number of events over a time period to the population at risk. So you can see there the rate of teenage pregnancy. We've had 200 pregnancies in ages 13 to 18 during 2010. And the population that we were looking at was there were 10,000 females in this community in that age group, and we counted that mid-year. So we put a line in the sand. We said, what about mid-year? Let's look at that. So we had 10,000 females, 200 of them got pregnant. That would be 20 pregnancies per 1,000 females, or 2 pregnancies per 100 females, or a 2% of the population. So it's fairly simple. It's not the same as what you have to calculate when you're doing IV drips and things like that. So that's the reason I really am not worried that you can do the math. I just want you to know what the concepts are. So it's basically that concept for all of our different formulas. So as you can see down here, we might have an annual infant mortality rate, and we would take the number of deaths during the year, birth to age 1, which we would consider that infant age, and we would have that divided by the number of live births during the year, and we would times that times 1,000, and we would get how many we had per 1,000. And it seems that then we can start to compare those. So if we had 20 pregnancies for teenage girls in 1,000 of the population, we can look at that, and let's say we would want to do something that said, what about STIs among girls in that age range? And we would get a statistic there. Then we would be able to compare those. How many of the women that young women that were pregnant in that age group then had an STI? We could then also do a mathematical equation to compare those. So it just allows us to look at the data and say, is this important? So if we look at a mortality rate or a death rate, we want to know if it's going up or down year to year. We want to know if our interventions are working on them, and that's the reason that we need to do this. So here's for incident and prevalence rate. Again, I'm not going to ask you to do this. I just want you to know these terms. Okay, so then the next thing we look at as in epidemiology is we certainly are looking at causality, risk, and rates of occurrence. So causality, really we want to look at whether or not one thing caused another. I think that just makes sense, right? So let's look at the trials we're having right now with the vaccines for COVID. So they had one person, I think it was a female, I might be wrong, had a spinal infection from one of the COVID vaccines that they're trialing right now. And they need to know if there's causality. They need to know, is that person got a spinal infection because of the vaccination, or are they not related at all to each other because people get sick all the time? So it really has to look at what is the causality for us to be able to look at what is happening with an outbreak. And then we want to look at the risk. Is there an absolute risk for someone, a relative risk? Are they susceptible to it? If we are looking at COVID, we would say someone is susceptible to it if their immune system is suppressed. That was one of the ones that came out of. Recently, they've said if you're obese, you might be susceptible to it. If you might have a relative risk if you live with someone who's bringing it home. But we certainly aren't looking at absolute risks right now. We have not identified any. We don't know why certain people in a family get really deathly ill and others don't have any symptoms, or others don't catch it. So we're still investigating that. And then the rate of occurrence. And we would need to compare that between two groups, and we really haven't had a chance to do that. But we have tried to do that with some of the groups, like in certain countries. So I don't know if you were aware of this or not, but when this outbreak first happened worldwide, Sweden decided they weren't going to do any measures in order to shut down the spread of COVID. What they wanted to obtain is herd immunity. And if you have not heard yet of herd immunity, what that really means is that you have enough people in your population who are immune to a particular disease to protect those who are not immune. Let's just take this as a country, but we'll talk about it in terms of a nuclear family. If you had individuals, you had mom, dad, older brother, older sister, that are all have been immunized against measles, and then you have a young infant in the family, and the young infant is, their physical system is too immature to get a vaccination yet. But if they aren't exposed to anybody but those 4 people, that infant is not going to get measles, because those 4 people can't carry measles because they're all immune to it. And that's what happens with, on a larger scale, in a community or in a country, in a state, in a neighborhood, in a county. Herd immunity, that herd keeps those people that could be susceptible to that disease from getting it, because it really never overtakes that disease, really never overtakes that population. We had herd immunity for quite a few things, but we've been challenged with having some people in our population that are not vaccinated. And so you'll hear about herd immunity, but that's what Sweden wanted to do: expose their population to COVID-19 and create herd immunity as they build antibodies. The challenge is that it really didn't work that way. And so they are actually seeing, they saw a huge spike. They had to kind of have some serious conversations about what they were going to do about that. And now they've seen another huge spike. And so, good for them for wanting to try something else, but it really was against the medical advice of the World Health Organization, and it proved to be disastrous to certain individuals. So we are looking at really what is the process. And again, I will say a lot of these processes are the same or very similar to the nursing process, right? You try to figure out what's going on, you plan what you want to do about it, you implement some type of intervention, and then you evaluate whether it works or not and change your course if it doesn't. So for the epidemiology process, we look at defining the condition and determining the natural history of the condition. So has it occurred, has it always been here? We don't know what the origin is. Has it occurred from nature? Did it skip over from an animal to a human? How did that actually work? And that's one of the challenges, I think, if you watch some of the old sci-fi movies, you'll see this a little bit more, but it is one of the challenges they have. The reason they isolate some of the people that have gone to the moon when they came back is because they didn't know what actually lived up there and whether or not they'd be bringing home any infections to the world that we had not seen before. You identify your strategic points of control. So that's really important in community health. So we're not dealing with just a patient, we're dealing with a community. And does that mean we're locking you down? I have a son who lives in Chicago, and just yesterday, Chicago put Wisconsin on the list again. So if he comes up here and he visits me, he's supposed to quarantine for 2 weeks when he goes back to Chicago. So what are the strategic points of control? And that's what Chicago feels that's a strategic point of control, is quarantining their population who travels to certain states that are seeing outbreaks. Developing control strategies, just like I talked about, implementing those strategies, and then evaluating whether or not they work. Okay. Now, I'm going to show you 3 different models. The first one is a very common model. You'll see this over and over again, the triad or the triangle. There's one that's a web of causation model. I'm just going to show it to you in comparison. It really is pretty similar to other things that you have seen, but the determinative health model we've already talked about, so that'll look familiar to you. So the triad model really has to do with a host, an agent, and the environment. And so the agent is really the pathogen. That's what we're talking about, the pathogen that actually actually is the beginning of the disease in an individual. And the environment has to be conducive to that pathogen. It can't be hostile to that pathogen. So a lot of pathogens like warm, mucousy areas, a lot of pathogens like to be breathed into our lungs, that type of thing. And then it has to have a host, and that host has to be susceptible to it. If you have received immunities, antibodies. If you've already created your own antibodies, you're not a susceptible host, and you're not going to become ill from this agent that has actually gone into your system. And so that is indeed what we're talking about with the triad. Remember that agents can be kind of infectious agents, but we can also talk about physical agents and chemical agents, and you know, those types of things. Chemical warfare, those kind of things would kind of fall into this. Okay. And the web of causation, this was developed in 1994 and suggested that we need to look for the spider in the web. We need to look for what actually is causing all of these to be connected. And it looks at both direct and indirect causes, and allows the epidemiologist to map the interrelationships between the factors. So this is kind of a working model. This is, you know, you may put this up on a big wall and you may say, this is what we know about this. What are the connectors? You can almost see that sometimes on those crime shows where they're trying to connect, you know, the neighborhood to where the crimes happened, to who was actually in those areas. You see all the string up there. That's kind of the same thing. And then we've talked about a determinants of health model. So this really is the one that's used by the Public Health Nursing Association and by Public Health Association. But it's looking at what are those things that are going to determine whether or not a population gets sick. And it can be used in communicable diseases as well as in things that are behavior driven, such as tobacco smoking, but it also can look at TB outbreaks. So what are the determinants within there? Are we having people that are a large immigrant population that have not been tested for TB, that may have it latent, and now it's becoming under stress, it becomes active, and now you're infecting individuals, that type of thing. Those are the things that they're looking at. So this is just a summary of what we talked about for this part of it, which is epidemiology, concerned with the development and understanding of factors that influence the health. Originally developed to use in examining communicable diseases. It can also be used any health-related issue now. And population health nurses use these strategies to assess health in the population and identify the factors they need to impact. Okay. Now we're going to talk a little bit about communicable diseases, because I just want you to be clear on this. So an infectious disease is an illness that results from the growth of a pathogen in the body. And this could be any pathogen. It could be a pathogen that normally lives on our skin, and we call it an opportunistic pathogen, which means maybe we get a cut and we already have the kind of staph on our, on our skin, and it's really not bothering us, and we wash it off, we keep clean, but now it's gotten into this, this environment that's going to allow it to grow. And so it grows in the tissue, and the staph now becomes a problem. It's an infection. That's different than a communicable disease, which is where the pathogens can be transmitted directly or indirectly from one person to another. So we have infectious diseases, and the infectious disease may be communicable, but we have communicable diseases. It's a much smaller subset. It's saying that I can get that from you, or you can get that from me, either directly or indirectly. You can cough on me, or I could touch a surface and you could get it, that type of thing. So it really is two different concepts, and I do want you to be clear on that. You probably have already gone through mode of disease transition in your med-surg class, but I wanted to revisit it. So we have certain ones that are airborne, certain ones that are fecal oral, and we see that a lot in areas that have poor sanitary condition. We might see that with children who have poor hygiene, that oral ingestion. And it doesn't mean that they're eating feces. It just means that they've gotten those microbes on their hands. Maybe they don't wash their hands after they use the toilet, and they have then eaten their lunch, and they may have gotten those. We have direct contact, we have sexual contact, which all of these are ones that I was very used to dealing with at the free public health clinic that I worked at, because it was a sexual health clinic. And then we have some that are really direct inoculation. In other words, you really need to have that in your system. So a classic one would be an HIV infection, where there has to be bodily fluid that is entering from the person who has it, the host. It has to be entering then the person that is susceptible to getting it. And then we have insect or animal bites. Of course, we all know about malaria and rabies. Lyme disease is caused by ticks, and the bubonic plague, which is caused by flea bites. And then other modes could be actual transmission of that agent, tetanus. We know about that. If you're going to work ER, you're going to be asking every patient when their last tetanus shot was. And hookworm is the same way. So these are just some of the modes of transportation. I just wanted to revisit that with you. So let's look a little bit at the incubation and prodromal periods for infectious diseases. So someone, let's say we're going to follow this timeline. Someone is exposed to the flu virus. Let's say they haven't gotten their flu shot, or it's a variation of the flu that that was not included in the shot this year, right? We only get our inoculations or our flu shots against usually the 4 or 5, sometimes 3 most prevalent strains that the CDC has guessed, and the World Health Organization has guessed. Their best guess. They're brilliant people to guess this, but it's just their best guess at which ones are going to be prominent this year. So you get exposed to this. You have an inoculation period. You don't feel bad at all. And then you might start to have what might be cold-like symptoms. Or if you're me, you think it's seasonal allergies. My nose is a little stuffed, my eyes are a little itchy, my throat's a little dry. And the period from when you first start feeling those symptoms until you actually know that you've got, influenza, that's called this prodromal period. And the prodromal period is really about, you're very infectious at this time, but we don't know enough to isolate ourselves. And that's been the big problem with COVID, right? We don't know when we actually have it at the beginning, and we might be spreading it out to people. But then you have the acute period when you're actively sick, hopefully a decline period, hopefully you don't succumb to the illness, and then a period of convalescence as your symptoms start to go away. But it really is this period between incubation and then from when you know you actually have something. That's the scariest for some of these. And, for coronaviruses, it is historically 2 weeks. And that's the reason they defaulted to that at the beginning before they knew too much about it, but it is 14 days. And they have kept that because it seems to be working. Now, there are different ways that you can get antibodies to resist certain diseases. So let's look at them. You have an active way to get your antibodies and a passive way. So the active way is that your body has actually produced the antibodies. It's produced in my system. And so it might be naturally, I got the cold and now I have developed antibodies, and that I now carry those antibodies, and I've developed those naturally. I went through the illness myself and developed antibodies. Or you might have a pathogen that's introduced through vaccine. So some of the early vaccines were live vaccines. They were just a very minute dose so that you would create antibodies, but hopefully not enough to get you deathly ill. And so that was artificial active immunity. So if someone's got COVID, right now they're creating antibodies themselves when they have COVID. And what we're waiting to find out is how long we keep those antibodies, if they indeed go away, or if we keep them indefinitely. We do have some documented cases of people catching COVID more than once, which is pretty scary. But I did share with you, my son Jeremy has donated plasma 3 times. He had COVID, he's created antibodies, he's donated 3 times, and he knows all 3 times of where those antibodies were used to convalesce an individual who already had it. Thus we go to passive immunity. So passive immunity, so it might be natural, such as it's crossed the placenta to the fetus. I have more than a few kids, and all of my kids had chickenpox when I went into labor with my youngest, and I had her and brought her home to a house full of children with chickenpox. And lo and behold, she never contracted chickenpox. And I would like to say it was because of my expert mothering care, but I doubt that that was the case. But it was from the fact that she probably had my antibodies for the first 6 weeks of her life that had crossed the placenta. And she ended up eventually getting this chickenpox vaccine as an adult, because she never really got it like the other kids did. So that would be a natural passive immunity. Artificial, though, are the ones that we also know about. So antibodies are actually injected into a person. So a tetanus injection would be this, and it would be the plasma injections that we have had. So we create antibodies ourselves on this one over here that says artificial immunity. We create antibodies ourselves. That's when you create antibodies from a vaccine. Okay. All right. So the only other thing, I'm going to stop sharing here. What you have then to finish up for this week. So week 5 is there is a, in Blackboard, there is an assignment, and it is called Critical Thinking Activity Epidemiology. What I have done is you're to fill this out, but I actually am giving you till the end of next week, because in the actual face-to-face class, by the time we got done with the lecture, we really only did the matching part and then into some of the other ones. So we're going to finish that up in week 6. So as soon as you finish it, drop it in the Dropbox and you're done with it. It really has a matching part on the beginning of it, and then it has a kind of a short case study that has, I think, let me look here real quick. It has like 6 questions on it. So it's possible that you can finish it in one sitting, but go ahead, finish that up, drop it in the Dropbox, but just know that you have until next week if you want to have that time. As always, if you have any questions on anything, give me a call, drop me an email, text me, and let me know, and I'll be happy to address them. Okay? Have a great week.